عليكم. بسم الله الرحمن الرحيم. يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير. السادة ضيوف الكرام كل باسمه ولقبه، السلام عليكم ورحمة الله وبركاته. لمن دواعي سرورنا أن نعلن بكم ومعكم انطلاق فعاليات المؤتمر العلمي الدولي السادس لجمعية القلب والصدر العراقية، وبحضور نخبة من الأطباء والزملاء المحليين ودوليا، شاكرين لهم قدومهم لمناقشة التحديات في طب القلب والصدر، ليتسنى للجميع تبادل الخبرات كبداية لجهود متواصلة. فأما بعد، لنستمع لتلاوة عطرة من آيات القرآن الكريم يتلوها على مسامعكم الأستاذ والدكتور القارئ دكتور مثنى العسل.
السلام عليكم ورحمة الله. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. حاميم والكتاب المبين. إنا أنزلناه في ليلة مباركة إنا كنا منذرين فيها يفرق كل أمر حكيم أمرا من عندنا إنا كنا مرسلين رحمة من ربك إنه هو السميع العليم. رب السماوات والأرض وما بينهما إن كنتم موقنين. لا إله إلا هو يحيي ويميت. ربكم ورب آبائكم الأولين بل هم في شك يلعبون فارتقب يوم تأتي السماء بدخان مبين يغشى الناس هذا عذاب أليم. ربنا اكشف عنا العذاب إنا مؤمنون. صدق الله العلي العظيم. رجاء الوقوف دقيقة واحدة وقراءة سورة الفاتحة على أرواح شهداء العراق وشهداء الحشد الشعبي المقدس. شكرا جزيلا.
والآن ليقف الحضور الكرام تحية للسلام الجمهوري. أما الآن مع كلمة الأستاذ الدكتور قاسم محمد سلطان الرئيس الفخري للجمعية.
السلام عليكم. أنا الأستاذ الدكتور قاسم محمد سلطان. نرحب بكم بمؤتمرنا هذا اللي هو المؤتمر السادس للانترناشونال والريسبيراتي اند كاردياك هيلث ويل. نتمنى لكم النجاح للمؤتمر وللشركات المشاركة، وإن شاء الله نشوف المؤتمر إن شاء الله جيد إن شاء الله. السلام عليكم. أوكي، ثانك يو. شكرا جزيلا، شكرا جزيلا. يتقدم.
والآن مع كلمة رئيس الجمعية دكتور مثنى القريشي.
السلام عليكم ورحمة الله وبركاته. الزميلات والزملاء، الحضور كلهم بعنوانه المحترمون، باسم الهيئة الإدارية جمعية القلب والصدر العراقية أرحب بكم جميعا في مستهل مؤتمرنا المؤتمر الدولي السادس للأمراض التنفسية، متمنيا لمؤتمركم هذا كل النجاح والاستمرارية. أتقدم بالشكر الجزيل لجميع اللجان العلمية والتحضيرية والمالية والإعلامية على جهودها المثابرة في إنجاح هذا المؤتمر. أيضا أتقدم بالشكر الجزيل للشركات الداعمة وللشركة المنظمة. وحقيقة حملني الأستاذ الدكتور عدنان الجبوري وبعض الأساتذة أمانة قبل أسبوعين من المؤتمر حول ضرورة تأسيس جمعية الجمعية العراقية للأمراض التنفسية. وإحنا تعرفون هذا المؤتمر الحمد لله هذا النسخة السادسة أيضا بدت بتريجر من اجتماع ثلاثي أو رباعي بين أساتذة أستاذ عبد الحميد، أستاذ عدنان، أستاذ محمد وهيب، بقية الزملاء ما أتذكر الأسماء. وبدت الفكرة والحمد لله هاي 6 مؤتمرات تنظمها الأمراض التنفسية. أتذكر العام من رحت للكويت أقدم برزنتيشن لانضمام جمعية العراق، جمعية القلب والصدر العراقية، جمعية القلب الخليجية، دكتور مثنى العسل يتذكر. البرزنتيشن كان قدمت نص ساعة على تاريخ الجمعية. من بدأت ديسكشن من الهيئة العليا ربع ساعة من الديسكشن انتوا ليش جمعية قلب وصدر ووين اكو جمعية قلب وصدر. طبعا فعلا it is time to نأسس جمعية الأمراض التنفسية ونستغل هذا الحضور الكريم ونجمع تواقيع لانضمام لتأسيس جمعيتنا الفتية. إن شاء الله المؤتمر السابع يكون برعاية جمعية الأمراض التنفسية العراقية. شكرا جزيلا على الحضور وأتمنى لكم الموفقية.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. جمعة مباركة على الجميع. خير ما نبتدئ به مؤتمر جلسة بمحاضرة علمية عن ال Biological Revolution in the Treatment of Difficult Asthma يلقيها علينا الأستاذ الدكتور راشد سلمان. دكتور راشد سلمان is a consultant respiratory physician with a special interest in difficult asthma and long COVID. The Leeds Teaching Hospital NH Trust. تفضل دكتور راشد.
The second one. This one?
Sorry, no, it's the opening ceremony. There it is.
Thank you.
And
Super, thank you so much.
this is yours.
Yeah, fantastic, thank you. Super,
And
that's,
there's the clicker.
thank you so much.
Do you need anything else?
up to, ما مشكلات لا لا شكرا.
Okay, is the clicker working? Yeah, it's working from here. I'll tell them.
اوكي بس ما ادري يطلع هناك اذا اوكي يا اوكي 20 دقيقة ولا 30 دقيقة؟ 30 اوكي فانتاستيك.
نحاول نختصر.
هو راح احاول
ناخذك بالليل نسوي.
راح احاول. شكرا جزيلا. as Mohammed Wahib said, I'm a consultant respiratory physician in Leeds, Yorkshire. صار 17 سنة مجال العراق ورب صدفة بخير من ألف ميعاد من فيينا بERS كونفرنس وصار الدعوة فشكرا جزيلا للكل. الموضوع really long and complicated, but it's only 30 minutes. I'll try my best to summarize as much as possible. I'm not going to teach you about oral corticosteroid problems, but we're just going to show you some evidence on that. It's worth mentioning that my special area of interest is clinical research and clinical trials. So this is research heavy, but trying to make it clinically relevant to the meeting. There's a few advancements there. However, last week I was in the British Thoracic Society meeting where the new guidelines for asthma are being published. And a lot of what we're going to talk today probably need updating anyway. So take it with a pinch of salt, but I'll do my best. Even in UK, asthma-related death is still a major problem, despite one of the most developed health system, and it's still a big issue, despite all the advancement in treatment. So still a lot of work to do. We all know steroids are bad, oral corticosteroids, but there are more evidence happening in the last 2-3 years where we can quantify the toxicity of oral corticosteroid. This is a study by David Price, and they followed up people who had 2 courses of prednisolone the year before randomization and followed them for about 8 years. And that's the hazard ratio of all these problems. So we're talking roughly about a 3-fold increase in most of the clinical condition you can see here. In particular, as you know, osteoporosis, heart failure, etc. So big burden. And if you want mortality figures, if you take oral corticosteroid, your risk of mortality do increase. And these are evidence for that. We all know that, but put it in clinical data to show how bad things are as it stands for asthma treatment. It's really important. And it's just changing the mindsets for oral corticosteroid usage. And this is just an opening statement to what's coming next. That's where the biologics coming into play. I don't think you can do asthma talk now without put this slide on. Fortunately or unfortunately, about 15, 20 years ago, nobody cared which interleukin involved in asthma, etc. Nowadays, this is a must to understand asthma and manage asthma. Again, not I'm here to lecture you about pathophysiology of asthma, but for those who are not as familiar as much, this is the epithelium, and you get triggers, any sort of triggers, virus, smoke, etc. And you end up with what we call it alarmins, which is the upstream signals, which lead to downstream regulations of interleukins, and then that leads to reaction. The main ones are allergic reaction, which is predominantly mast cell driven. The other one is IL-13, IL-4, and the other one is IL-5 driven, which detected by eosinophils. Now, I'm not a pathophysiologist, I'm not an immunologist, but I'll show why this is really important to understand in terms of how to treat difficult asthma patients with inflammatory asthma. This will lead to a phenotyping of asthma, whether it's allergic inflammation, whether it's eosinophilic inflammation, or whether it's beyond T2. And for those who are unfamiliar with the term T2, an inflammatory asthma nowadays, it's TH2 high. It's about the immune response. And we're trying to split TH2 high from TH2 low asthma. And the idea of that, we can detect that clinically, and then we can act on this type of asthma differently. This is what's called the bucket slide, which basically show you the alarmins, especially this one, if you can keep an attention of TSLP, thymostromal lymphopoietin. And then you've got the downstream regulations, which is IL-5, IL-4, IL-13. These are downstream T2 cytokines. These are upstream T2 cytokines, or alarmins, as it's called. The reason for that, these are responsible for all the symptoms of asthma that you're aware of. Bronchospasm, etc., airway narrowing, mucus plugging. And the detection of those happens particularly through blood eosinophils, serum IgE, and FeNO, fraction exhaled nitric oxide. And based on that, you can decide on treatment. For those who are not familiar with FeNO, it's an easy way to measure airway inflammation. You just do a steady breath for about a minute or less. You just keep the thing in the middle. So it's a tidal volume measure, really. You don't need much of effort. You just need to sustain your breathe for about a minute. So it's much easier than spirometry to do. Values above 50 indicate airway inflammation. Below 25, almost certainly rule out airway inflammation. Now, I talked about asthma guidelines last week in UK. هذا راح يكون the major diagnostic feature for asthma, and that's embedded in guidelines as per last week. بس ما صار عندي مجال update the slides, so maybe it's a talk for another year for the new asthma guidelines. It's completely changed the approach. Salbutamol almost dropped of asthma management completely as per last week. So FeNO is essential, and I think moving forward, it will be very hard to avoid dealing with FeNO. The future is definitely FeNO. It's not only good for diagnosis, it's good for compliance with the treatment for inhaled corticosteroids and for indication for biologics. Why it's important? That a study show you how much asthma you can miss by relying on spirometry. So you get a normal spirometry at the time you do the spirometry, where the patient have a normal airway, and you can detect about extra 18% patients who you wouldn't diagnose without using FeNO. So diagnostically very useful. Sorry, I have to speed up لأنه we're running short out of time, but we can talk about this later. If you can't remember anything, just remember this slide. That's where your phones can come up. This is the Oracle risk stratification from the Oxford group, Professor Ian Pavard. Unfortunately, it happened in COVID time, but they looked at about 2 to 3 years worth of asthma exacerbations in UK. The UK has the largest registry of asthma in the world. They're كلها centralized. It's a public health system, so all the data comes to one pool. So they could look at every single asthma exacerbation in the United Kingdom. And what they did, they measured 2 things. FeNO, which is on the y-axis, and the blood eosinophils on the x-axis. And they asked 2 questions. 1 question, sorry. Has the patient had asthma attack in the last year? No or yes? And they split the 2 groups. And what you can see, don't know if this works. I'll try to shout, but the bottom left, if you can see the green, the 0.06 square, the bottom left in the corner. So that's a patient who's got FeNO less than 25 and the blood eosinophil less than 300 and had no exacerbation. The risk of another exacerbation in the next 12 months is almost 0. While if you look at the top right corner, the red, it's a patient who had exacerbation in last year, had FeNO above 50, and had eosinophil above 300. The risk of another exacerbation in the next 12 months is almost 300%. So you're almost certainly going to have exacerbation there. Now, this is probably not unexpected. Someone got high eosinophil, high FeNO, had the previous exacerbation. You'd expect them to have another one. But if you look at, I might need to point it with my hand. Sorry. These are patients, according to GINA guidelines. They're doing very well. They're only on step 1 of treatment. They're really, really, really stable patients. But look at the risk of exacerbations. Because they have high FeNO, high eosinophils, the risk somewhere between 60 to 80% of another course of steroid in the next 12 months. And this is where the thinking about how we stratify patients with asthma is changing significantly. So if you follow the symptoms, you might miss a lot of unwell patients that are likely to have problems in the next 12 months. If you phenotype them and objectively test them, you're likely to spot much more early patients who's at risk of deterioration. And that's lead nicely to the biologics talk that we can talk about. By the way, it's called the Oracle risk stratification. Okay. No مشكلة. Worldwide study, well respected, and changing a lot of what we're looking at patients' treatment. So you have two dimension. You can have someone who has airway disease, had multiple courses of steroids, end up with a lot of steroid-related problems, had all the stuff that we know very well they're not going to work on those patients, like Montelukast, tiotropium, unifilan, all that sort of things. The other alternative, you have a patient who's got high inflammation, Th2 high disease. You spotted it early, had 1 or 2 exacerbations, and you start them on biologics, and you save them a journey of complication with the steroids, as I've alluded to in the first slide about the risk of steroids. So that's where the changing and the thinking is happening. The summary is Th2 disease is ultimately need an anti-inflammatory treatment. Montelukast, unifilan, Spreva, Respimat, or any anti-muscarinic agent is not going to work. You know that, because the primary problem is a Th2 inflammation. For that, you need either steroid, oral corticosteroid, which we know is very bad, or you need immunotherapy to treat that. And that's the idea move into biologics. That's the evolution of biologics options in a chronological order. So the first one was omalizumab back in November 2007, and this is as it licensed in the UK, so they're probably a year or so before that. In January 27, mepolizumab was, which is Nocala. March 19, benralizumab, which is for Cerner. We have in the middle something called reslizumab, which is a nightmare and not involved here because it's infusion, so it's not listed. Then you have dupilumab, which is December 21. And then you have tezepelumab, which is a very different cuttlefish. It's a completely different approach to treatment in April 23. Dupilumab, I had a few slides for, but I think I saw in the John Hurst is talking about COPD, so I'm sure going to mention Dupi. But it's now licensed for COPD with eosinophilia, which is another new thing. I'm not talking here about COPD, but it's another talk. So that's the historic evolution of these biologics. So they've been in the market for about 17 years now, so not very new. Not to dwell too much, but these are the mechanism of action of each biologic. But generally speaking, there are four, at the moment, there are four mechanisms. IgE, which is the old sort of out of fashion, Xolair, omalizumab. We don't use it as much anymore. You have the anti-IL-5, which is the most common used. There are about 5 million people in the world on them at the moment. That's anti-IL-5, so that's mepo or benralizumab. And then you have the anti-TSLP, which is Tezspire at the moment. And again, it's very, very interesting. That's to recap on things. So if you have an IgE-dominant disease, omalizumab is your choice. If you have a pheno-driven disease, which is related to IL-13, dupilumab is your choice. If you have an IL-5 heavy disease, which is serum eosinophil, then you have these are your options there. There are more in the development that you can ignore them at the moment. However, TSLP, tezepelumab, it almost cover every single patient with inflammatory asthma. Because if you remember, TSLP is a high, I'll go back to it, it's a high alarmin. So it works here, which is a new approach altogether to treatment of asthma. So literally, if you like, يسد البوري من فوق. So there is nothing coming down. So it's very, very interesting, innovative approach. I remember, very important slide, the bucket slide. So this is where we are at the moment. This is what we have so far. However, there are 17 biologics in development at phase 3 trials. One of them will be licensed next year, which is depot. So it can be given twice a year. So 6 monthly injection. Most of these are 4 to 8 weekly injection, apart from Dupi, 2 weekly injection. So Dupi is every 2 weeks. These are benralizumab every 8 weeks. Mepolizumab every 4 weeks. Tezi every 4 weeks. Xolair is a nightmare. So omalizumab is a nightmare to dose, and that's one of the problems why it's not used much anymore. It's a subcut injection. Patient can do it themselves. So, and it's like insulin pen. So it's not a true injection. You just click it in. You just press a button. So we're just going to go through a bit of efficacy on each of single biologics. Just a quick summary on these most common ones. So omalizumab or Xolair, as mentioned, is a predominantly anti-IgE agent. These are the efficacy in terms of all the meta-analyses, a study for exacerbation reduction with omalizumab. And if you don't need to be a statistician, but it's roughly about 30 to 40% risk reduction of exacerbation. So remember that number, 30 to 40%. The biggest problem with omalizumab is variable dosing because it's weight dependent and IgE dependent. So it's really hard to dose the patient properly, especially if your patient is very obese. It's completely out of the question. Limited indications, has a very limited indication because it's IgE mediated. and low efficacy, 30 to 40% compared to the later biologic options. You've got benralizumab, very, very widely used. It's 8-weekly injection, is IL-5R receptor blocker. Don't worry about the busy slide. It's 8-weekly or 4-weekly injection, but the key number is somewhere at the bottom, which is, sorry, there. So it's a 75% risk reduction of exacerbation. Compare 30% to 75%. Quite impressive. The thing about benralizumab, and that was we meant to do a talk about EGPA actually with biologics, but we didn't have time. Because it depletes eosinophils completely, it's a very effective tool in EGPA as well. EGPA without end organ damage. So if you have a predominantly EGPA that is ENT plus lung disease, very good option as well. And there are a couple of trials for that. You have dupilumab, which is very interesting, and it's the only one licensed in COPD at the moment with the eosinophilia. But again, the talk here about asthma. This is very useful if you have IL-4, IL-13 disease. So if you have a patient who has very high FeNO, but relatively low eosinophils, you know the main driver to their symptoms is IL-4 and IL-13. For those patients, dupilumab would be amazing. 2-weekly injection. These are the studies on dupilumab efficacy, and you can see wonderful 75% risk reduction if you have a FeNO above 50. So your relative risk reduction is about minus 0.25, which is about 75% risk reduction. The problem with dupilumab, it's a bit expensive, costly. There are some problems with eye problems and rare reports of seronegative arthritis. In fact, I did write a paper on seronegative arthritis and Dupi. So it's not risk-free option. This is just to compare Dupi and omalizumab, and not to dwell too much. We haven't got time, but Dupi is much better option. And then you have Nucala or mepolizumab, which is one of the most world-used biologic. And this is Reality A, so that's phase 4 trial. So for those who are not familiar, this is post-phase 3. You do real-world evidence data collection. The beauty of that, these are not clinical trials. These are patients who's been followed up from real clinical practice. And again, whatever you look at, there are about 70 to 80% risk reduction of exacerbation. These are not immune suppressants. These are not like rituximab or cyclophosphamide. These are very safe drugs. Hardly any risk of infection. Hardly any side effects reported. This is mepolizumab, but it's universal to all the biologics in asthma. They're really, really safe, so as far as we know. Apart from a bit of headache, a bit of a flu around the time of injection, hardly any problem reported so far. TSLP, again, remember that name, TSLP, thiamycin lipopoietin, high stream or upstream alarmin. Tezspire or tezepelumab does block that and literally block the whole flow of the signals. Again, very impressive data. You can see whatever you look at about 70 to 75% reduction of exacerbation. And the more TH2 high, the better outcome. So if you have high FeNO, high eosinophil, you do even better. Again, fairly safe in terms of side effects reported. We've cut a few slides. I'm being very quick, but I just want to focus on this because this is the other question. Someone is on inhalers. You start them on biologics. They're doing well. What do we do about their inhalers? Do we stop them? Do we carry on? What are the evidence for that? And up to 6 months ago, we had no evidence whatsoever. This is the first trial on patients with biologics on inhaled steroids. And this is from David Jackson, guys in St. Thomas in London. It's called the Shamal study, and I've told them Shamal in Arabic means north. So there are two figures, if you like. This is the general patients who are on inhaled steroids and biologics, which you'd expect that things get better as you start biologics. So in terms of your FEV will improve as you go on biologics. Your FeNO goes down because you're on biologics. So your Th2 disease get better, as you can see here. What they did here was, after you established on biologics on inhaled corticosteroid, they've randomized patients to 4 groups. Those who carry on their high dose inhaled corticosteroid, which is in purple. Those who go down to medium, which is in orange, and those goes to low, which is in green, and more importantly, those who stop their inhaled corticosteroid. And they follow them up to see what happened. And if you follow the red one in particular, sorry, you can see here, as you stop inhaled corticosteroid completely, almost immediately, within a few weeks, their FEV goes down and their FeNO goes up. So if you have no inhaled steroid whatsoever, you're in trouble a year later. While for those who are kept on low inhaled corticosteroid, they did have a dip, but they got better. The FeNO gone up, but they got better and steady. And what does that mean? If you're doing very well on biologics, we can wean down your inhaled corticosteroids somewhere down to low inhaled corticosteroids. But you do need a bit of inhaled corticosteroids regularly, no matter which biologic you're on, no matter how well you are on biologic. So, unfortunately, as much as I love it, but it's not the end of inhalers. It's just you can do very well with disease control, and you need a bit of inhaled corticosteroid with your biologics. Shamal study is a very good read if anybody interested in a state-of-art clinical trial and a clinical research in respiratory medicine. It's worth mentioning that difficult asthma with Th2 high is about only 3 to 5% of your asthmatic patients. So it's not very common. 95% of your patients don't need biologics, just need inhaled steroid and the basics right, like we all do. Good inhaler technique, good counseling, good diagnosis. But remember, if you have patient who is Th2 high and not responding to treatment, then there are options for them, albeit they are expensive options. What I can gather from here, please, if you have access and you have a patient who struggle with asthma, make sure you do 2 tests, FeNO and blood eosinophils, which is part of your full blood count. So it's a very cheap way to understand the disease of your patients. And sorry, it was much longer talk, but for the interest of time, I think, just to summarizing the findings, identify your Th2 high, do the basic rights. Biologic can do wonders for the right patients. Steroids is not an option anymore. Maintenance oral corticosteroid on long-term corticosteroid is almost a criminal and negligence in terms of medicine nowadays. Nobody should be on long-term steroids in asthma. Cost, obviously, is a big, big burden. However, mushkila is not relevant to the here, but in Europe, you work, you pay tax. If you don't work, the government has to pay for your treatment and things. So in terms of cost implication, if you have insurance or public health, it's actually not expensive because you'll pay it in tax, variable, etc. So here is a private funded medication. So affordability is an issue, but for the patient who can afford them, they're amazing. we can do a whole lecture on challenges, but the main ones are pregnancy. We don't have safety data in pregnancy, so if you have a childbearing age woman, it's an issue. It's not impossible to carry on biologics, but it's a concern. The other one is, what guidance do you have for treatment failure and switching, and based on what? That's a big problem as well. And duration, so far, is forever. You don't stop them. But things might change in the next sort of few years once we have more data and see whether we can switch off the inflammation. And I think that is the last slide. Shukran jazeelan.
إن شاء الله عندنا جلسة مخصصة ويا دكتور راشد إن شاء الله نشوفه في أمسية ناخذ أكثر من 2 hours. Now about the modern speak about the modern medicine from father of respiratory الأستاذ الدكتور عدنان الجبوري. You have a new subject about the modern medicine. تفضل أستاذ.
بسم الله الرحمن الرحيم. الحضور الكرام، السلام عليكم ورحمة الله وبركاته. About this modern medicine, Dr. Rashid has already talked about modern medicine. My talk is something different. I'm talking about future medicine rather than modern medicine. And modern medicine is actually a pathway to the future medicine. What actually face our we pulmonologists and maybe cardiologists as well, that we see those with the acute respiratory distress syndrome. It's a nightmare, you know, having patients with pulmonary fibrosis, COPD, chronic illnesses, COPD, with end-stage disease, and the only answer will be what? Just lung transplant, and it is not always successful. So the future medicine is talking about something that help those what is used to be impossible to deal with, and now we can, with the future medicine, we can help those people with, as I said, lung cancer, the cardiologist, congestive heart failure, congenital heart diseases, ischemic heart cardiomyopathy, cardiac fibrosis. All these can be dealt with the future medicine. The lung can be roughly divided into an airway and lung tissue. And the natural repair process occurs when there is damage to the tissues. And as the person gets older, the number of cells are getting less because of the damage to the tissues all over the body, including the lung and the respiratory system. But the repair would be occurring in young people more faster than old people. And as you can see, we are always talking about cells, number of cells. They are actually, when you get older, you get less cells in the body than when you are young. Some important facts that we have to think about. The natural repair process, healing from within, This is an important making impossible. This is the essence of future medicine, making the impossible possible, a promise for the future medicine. Like healing. You know, this is, if you have any trauma, then sometimes you feel that there is no scar at all, but sometimes there is scar. Scar, it means fibrosis. So there is what is called regeneration and degeneration. Degenerative process is a natural degenerative process. We call it natural because this is by the what is called inflammatory process. Whatever illnesses, there is always inflammation. And inflammation would end with what? With fibrosis and cell damage and tissue damage. So the natural repair process is the healing from within and prevent fibrosis, because inflammation can end into fibrosis or regeneration of tissues. And that's the whole facts about now, how many cells when you are born? It is around 100 trillion cells. When you are at the age of 70, it is 10 trillion. So it's coming down. So whenever you get older, you get all the tissues and the cells are damaged, and we lost cells. So the whole problem is cells. Now, imagination and technology has improved our things. Initially, it was science fiction, because technology that is used, for example, the cell phone. كان بالستينات كان ستار تريك تطلع، واحنا طبعا كنا نقول هذا كلام فارغ غير صحيح. لأن now it's true. Now we are having this. We can communicate and we can see each other from long distances. Technology and invention. There is no invention. There is actually discovery rather than invention, because it is already there. هو رب العالمين خلق لنا الجسم وخلق الخلايا، واحنا يعني من يصير science, where there is development in the science, then you can see and find things, pathways, any cellular, subcellular level discovery. وفي الأرض آيات للموقنين وفي أنفسكم. يعني بما معناته احنا رب العالمين يأمرنا يقول لنا روحوا فتشوا حتى we find pathways. يمكن الدكتور راشد حكى هواي أشياء على new pathways. Now this is future medicine. Now this is the first step for future medicine, looking for pathways which is already available in the human being. Digital طبعا هذا سهل علينا artificial intelligence، سهل علينا الاشياء. يعني مثلا انا هسه بالهايبرتنشن مانجمنت نقدر هواي بالديجيتال. هنا مثلا بالار سي يو سي سي يو نحتاج لنا، كان قبل نحتاج لنا فد 20 واحد، هسه ماشين وشخص واحد he can run too many people at the same time. So future medicine and now what is conventional medicine, which we are doing now, is actually one size fits for all approach. يعني free size. واحد عنده أسمة، هسه بدنا نحكي على الأسمة. شفنا أسمة they don't respond because we are having this guidelines fixed for everybody. While the future medicine, we call it precision medicine. Precision medicine. الطب الدقيق. What is precision medicine? We select. يعني every patient has his own structure and pathological problem. Like asthmatic having certain pathway, abnormal metabolic or genetic or environmental pathway that causes this damage to the lung, and the treatment should be directed to that specific problem and the same specific patient at the specific time and the specific medication, and way of therapy. Life span. اكو فد شيء يسمونه health span و life span لازم نتعلمهم. Life span العمر. عمر الإنسان. Health span is the time that you are healthy. You live normal and healthy, and aging process is as the natural aging process. ناس تكبر بالعمر. بس لازم شنو نريد من هذا العمر؟ لازم يكون health span. So this future medicine is directed to have a person with a health span rather than just life span. بالتسعينات بداية التسعينات كانت الكيميكالز ماتيريالز يعني الرينج مال العمر 40 at the age of 40 تقريبا المين ايج. بعد الحرب العالمية بدأت الفارماسيوتيكال كومبانيز دخلت قامت they improve the life span but not the health span. فبالنتيجة النهائية الأعمار قامت خمسينات وستينات. هسه بالوقت الحاضر ويا البيولوجيكال مودرن ميديسن وهذه قدرنا and now we are talking about 70 and 80. But with the future medicine we are talking about 150 and 200 years of health span rather than life span. يعني you live healthy. شو الفائدة؟ It gives you a longer, happier and more productive health span. That's the future medicine. Now, what are the ways that that there is the first steps of future medicine is already there, is already present. That's why we are talking about a future medicine, and everybody should know this future medicine, because I am sure that it would be the only medicine, and all the conventional medicine اللي هسه احنا نسويه would be obsolete at all. So that's why we have to learn this future medicine, at least نسميه awareness of this. And the first step is what is called regenerative medicine. يعني هي شنو lifestyle modification والشنو عندنا regenerative medicine. One of the tools for the regenerative medicine is gene technology, the improvement in the gene technology. And by gene technology, we can know too many things. Metabolic pathway, everything. Now, by the gene sequencing, we can diagnose all kinds of, it's beyond pheno, beyond, but it would be easy for us to diagnose any kind of illnesses, any kind, by gene sequencing. And you know that genes, how many genes available? إذا خلينا, if we stretch the DNA of one human being, شو قد تعتقدون نوصل للشمس كم مرة؟ تروح للشمس وترجع دورة للشمس 600 times. يعني مع الإنسان الواحد. فتشوفوا ايش قد بيها تفاصيل. Now the gene sequencing machines are available. And now they can diagnose all kinds of illnesses. هذا الأسماء نقدر نعرف أي نوع أسماء أي نوع defect, and we direct our management toward that specific gene. So we can replace, we can add, we can delete. طبعا هذا بالنسبة للريجنراتيف ميديسن. Precision medicine depends on this. Regenerative medicine بالمستقبل راح يصير عندنا ويا الموليكولر ميديسن والنانو ميديسن in the future. هسه احنا نعوف الفيوتشر because when we talk about nano medicine, now we are talking about the precision medicine depend on the nano medicine. طبعا هسه كانت science fiction, هسه real science. In the future would be pico medicine. Now, nano medicine, we are talking about near the size of atomic size. So it's very, very small. That's the regenerative medicine, I talked about it. That's an application in the respiratory system. We are talking about cells. Cells. So cells, it is very much complicated. It's not just one cell. Each cell has a specific cells that actually induce the damage. I mean, damaged cells. Say we have epithelial cells, and this epithelial cells is damaged. We have to replace this by the same epithelial cells with, and this is very busy number of cells. You can see a lot of cells. Lung cellularity is something beyond, and that is one of the way to deal with the by cellular therapy. Cellular therapy, you direct your treatment by giving cells that are already damaged in that specific organ, including the lung tissue. Also, the mesenchymal stem cells is actually has an anti-inflammatory effect and reducing the inflammation process. So it can help reducing tissue damage and promote healing. Tissue engineering. We can make tissues. We can make lung. We can make trachea using scaffold and too many new things. Here, it is done in the lab. Trachea has been done. But of course, this is not yet approved by the FDA for the human. This is for the animal. But if we are able to produce trachea, we are able to for the animal. We can make it for the human. Gene therapy, using the new machines, new technology, we can do anything. Modulating gene expression, يعني disease ليش يصير؟ يا اما عندنا over expressed or under expressed to produce illnesses. We can, by the future medicine, we can upregulate and downregulate, and we can heal the patients from the illnesses. Biologic and growth factors, peptides. Some of them, Dr. Rashid talked about this point. Rashad, afu. Okay. Growth factors to grow the cells that are being damaged. Exosomes. What's exosomes? Exosomes. كل ما بدنا نعرف شوية الخلايا أكثر. Exosomes are actually مثل messengers. يعني تعطي معلومات من واحد لواحد، من خلية لخلية. We can deal with cancer by exosomes. Exosomes. We can diagnose cancer before. هسه كل الحكي على early detection of cancer. Because if you detect cancer early, you can deal with it easily. Now, by using exosomes, because these give messages, and the cancers give certain messages, and these can be detected now. This is an established entity. You can detect any kind of cancer by using the exosome-specific, some cancer-specific exosomes. Repairing lung injury. There is damage to the lung. You can make you can make lung outside in the lab, or you can stimulate cells. You can inject cells that has been damaged by acute respiratory distress syndrome, for example, or pulmonary fibrosis, or COPD. All these chronic illnesses. Chronic respiratory. هذا طبعا هو نفس precision medicine نعتبره personalized or customized medicine. مثل ما قلنا chronic respiratory diseases, pulmonary fibrosis, COPD, pulmonary hypertension, which are actually, it is a dilemma. I mean, nobody can help those people. But with the future medicine, we can. Clinical trials, قسم منها وصلت phase 2, phase 3. There is a lot of work on this aspect. We need some time to get the result, whether this is safe and effectiveness of these strategies. Lung cancer, as I said, bioengineered lung. So this is bioengineered lung in the lab. They make lung outside, and you can insert this to a damaged lung. مكالمة تأخذها من خلايا جسم الإنسان نفس الإنسان. فما there will be no rejection like what happened if you give the conventional lung transplant. Conclusion, it's a shift for the new approach of medicine, and I actually insist on you all get some awareness of this future medicine, because it would be an established medicine in the not maybe near and the possibly little bit remote time. When we talk about this future medicine, we are talking about cure. The conventional medicine, it is not talking about cure. It is helping, relieving symptoms of the patient rather than cure. With the future medicine, we are talking about cure. And thank you for listening. وبس حبيت يعني انطيكم فد اعلان الحقيقه. يعني احنا قلنا regenerative medicine هو يعتبر part of the future medicine اللي نسميه خلينا نقول عليه precision medicine. One of them is important part is regenerative medicine. فهسه اكو البورد الامريكي الحقيقه هو يمكن البورد الوحيد اللي بالعالم يعطي دبلومه اوف regenerative medicine. واحنا قدرنا، هاي صار سنوات طويله، قدرنا نجيبها للعراق، فسوينا عراقي شابتر. تخرجت دوره اولى من هاي الدبلومه، وانصحكم كلكم تدخلون بيها، لانه الكورس اكو قريب الثاني هسه راح ينفتح. والحقيقه هذا الاعلان مالته، هذا الاعلان مال البورد الامريكي هو بس احنا ترجمناه بالانجليزي بالعربي. والكورس هو عباره عن ثلاث اشهر. الحضوري فقط يومين، خميس وجمعه، والبقيه الايام يعني 3 اشهر الاخ اونلاين، كله اونلاين. واللي يعجبه يحضر، يسموها اكو جلسات كلينيكال، يعجبه يجي خليجي، بس هي تنقل بطريقه الاونلاين. والامتحان يصير بعد ال3 اشهر. 3 اشهر كورس، 2 يومين حضوري، خميس وجمعه ما ياثر على، بس الخميس لازم واحد ياخذ اجازه، ولازم حضوري كوندنس كورس. واحنا طبعا الباينير بالمنطقه. بعدين هسه صارت الامارات صارت ورانا، وتركيا صارت، يعني في الدولتين 3. طبعا مكانات اعتقد باليابان صارت، وبالكوريا كذلك. بس احنا الحمد لله قدرنا هذا، اكو نشاط بالعراق. طبعا تارجتد بيبل، مو بس الكونسلتنت، لان احنا نريد جيل الشباب، جيل الصغار هم راح يصيرون اخصائيين المستقبل. فاتوقع ان شاء الله هذه يعني ننصحكم هذه اذا تاخذونها صوره.
شكرا جزيلا للاستاذ الفاضل عدنان الجبوري. لا ننسى في هذا المؤتمر ان نستذكر اساتذتنا، الاساتذه الاوائل اللي هم الكونفرنس بايونير، اللي هو الاستاذ الفاضل الدكتور فائق الالوسي، الاستاذ الدكتور نزار باقر الحسني، طبعا يهديكم احلى السلام. حاول ان يجي بس شويه حركته بطيئه ما قدر. الاستاذ الدكتور حمزه عبد الله الصباح، الاستاذ الدكتور ظافر سلمان هاشم، الاستاذ الدكتور هاشم الكاظمي، ان شاء الله يعطيه الصحه والعافيه يقوم من اصابه، الاستاذ الدكتور عدنان الجبوري، الاستاذ الدكتور وليد مصطفى، الاستاذ الدكتور الشهيد محمد عبد الله الراوي، الاستاذ الدكتور فيصل حبه. عندنا الوقت كلش مركز، ما نقدر لان ورانا سيشن كلش، لان بدنا جلسات. عندنا 10 مينت بس، ناخذ كافي بريك ونرجع اخوان. كافي بريك 10 مينت نوت مور ان شاء الله.
تمام.
عليكم السلام.